Hello, I'm excited to tell you all about my proposal for a scholarly project that focuses on introducing evidence-based practice into the clinical setting using the Iowa model for evidence-based practice as a guiding framework. For this project, I am taking a look at why and how to implement routine screening for post-stroke depression in an outpatient clinic. There is a known association between stroke and depression. This was first identified in controlled studies in the 1970s, but has actually been a recognized association for over a century. At least two meta-analyses have found that about 30% of the projected 700,000 patients expected to have a stroke this year will develop depression, at least at some point in the 5 years following diagnosis. The phenomenon is not entirely understood, but it's believed to be associated with vascular depression and chronic small vessel ischemia, suggesting that an ischemic event can create a cascade of brain changes. These changes follow the same pathophysiology as a slowly developing vascular depression, but are believed to happen suddenly following a stroke. Depression is not an unexpected sequela of any disabling illness. However, studies that compare depression in stroke patients and similarly disabled orthopedic patients found depression more prevalent within the stroke population. While the timing of post-stroke depression isn't completely clear, the most severe depression is correlated with the first year of recovery. Post-stroke depression, which affects again about a third of all stroke survivors, and is associated with an increase in all-cause mortality, more frequent subsequent hospitalizations, and longer hospital stays, as well as decreased adherence to lifestyle modifications and medication regimens, remains an elevated risk for recurrent stroke. PSD is also associated with poorer quality of life for both patients and their caregivers. Rates of diagnosis of PSD identified in routine practice are only about 5%. This is much lower than in studies that looked at screening for PSD and suggests that many patients with active PSD remain undiagnosed. And this is true despite the obvious impact of depression following stroke. The complexity of screening and how our clinic may address these concerns will be explored further in this presentation. As part of the movement to incorporate existing evidence into actual clinical practice, a spirit of inquiry is required. Why is post-stroke depression so underdiagnosed? How can our clinic adopt the best practices to better identify this at-risk population? The Iowa Model Revised was created in a response to the challenges of translating research into real-world clinical practice. And it was felt to be a good fit to guide the possible implementation of routine depression screening in the outpatient stroke clinic. So bear with me while I break down the major steps in the model. First, a problem or trigger is identified. In this case, a guideline that's not being followed. If both a problem and the mandate for a solution are confirmed, the next step is to form a team. This team begins the development of a research or PICO question, and then synthesizes and evaluates the evidence. The team determines that there is sufficient research to both uphold that there is a problem and also offer potential solutions. Or they do not, but hopefully in this case we have. The team then recommends a plan for the implementation of change in the form of a pilot. Following the pilot, an assessment is completed to determine the effectiveness of the new strategy. Then, an ongoing feedback loop helps to determine if the outcomes of the intervention remain congruent with the stated initial goals of the project. The PICO question is considered a crucial step that should take place early in any evidence-based process improvement project. This question, which identifies a population, describes an intervention, and contrasts the intervention with a comparison, and finally an outcome over time, helps to clarify a perceived need. The purpose of the PICO question as the tool for developing specific search terms that help to find the very best evidence available. This evidence can then be used to answer the urgent questions that arise within the clinical setting. In this case, in the stroke population, how does the use of a formal depression screening of patients, in comparison to usual care, affect identification of signs and symptoms associated with post-stroke depression in the 6 months following hospital discharge? Now that we have our PICO question to help us narrow down our literature review, just how is good quality evidence identified? Each research study and article were evaluated using the Johns Hopkins Nursing Evidence-Based Practice Model, which includes a set of appraisal tools to evaluate the strength of quantitative and qualitative research as well as a non-research. The tools guide the evidence appraisal by categorizing each article or study into one of 5 levels of evidence. Level 1 indicates the highest level of evidence, such as a randomized controlled trial, while Level 5 is assigned to a literature review or expert opinion. Levels 2 through 4 fall in between and include quasi-experimental studies, clinical guidelines, and position statements. The quality of the study is also assessed with a grade, A, B, or C. Grade A indicates sufficient sample size, consistent methods, and definitive conclusions, while a grade C is reserved for inconsistencies and insufficient evidence. The majority of 13 research studies evaluated for this project were assigned a quality level of A or B. One study was included for its similarity to the population identified in the PICO question, but did receive a quality rating of C for small sample size. In addition, the position statement from the American Stroke Association was also evaluated. The Agree-to Appraisal of Guideline Research and Evaluation tool was used to evaluate the American Heart Association, American Stroke Association 2019 guidelines for the treatment of ischemic stroke. A review of the literature, as well as a review of national guidelines and a position statement from the American Stroke Association specifically dedicated to post-stroke depression, support that the underdiagnosis of PSD is quite a cause for concern. While the American Heart Association guidelines strongly recommend using a depression screen and outpatient follow-up, they don't specifically identify a screening tool, nor do they suggest the best time frame to do so or the frequency. So now we have uncovered why so few outpatient stroke follow-up assessments include depression screening, and we also have some work to do. So exactly what were the conclusions we came to after the synthesis of quality evidence was completed? There was actually enough evidence to make 2 recommendations. One was that the implementation of routine screening for post-stroke depression was appropriate for our outpatient clinic practice and important. And 2, that there was enough quality evidence to recommend using the PHQ-9 as our screening tool in our pilot. Of note, it's important to note that no screening tool is diagnostic, but it is used in the to aid the clinician in making evidence-based decisions, and this is in collaboration with the patient's family, and other members of the care team, incorporating patient and family values. So great. Now we have these recommendations, but still this hasn't been done not only in our clinic, but around the country. So there still must be several barriers to routine screening. The barriers are diverse, but they include a lack of knowledge from providers, busy outpatient office schedules, limited financial and training resources, no validated screening tools for specific use with stroke patients, unclear pathways for those that actually screen positive for depression, and a concern about the level of evidence for the treatment of the depression once it's identified. So the circuitous nature of these barriers leading to inaction has actually resulted in the decades of knowledge about the prevalence and significance of post-stroke depression without any significant momentum in identification and treatment. So we're going to try to get out of that quagmire, and the goal of our evidence-based practice improvement project is going to more narrowly focus on the identification of an appropriate screening tool and the implementation of that tool in practice. Thankfully, we don't just have barriers, we also have some facilitators for the implementation of this evidence-based practice project. First, this fantastic team. The passion for providing excellent evidence-based care is evident in all of our providers, and this is a dynamic team that consists of early innovators of change. Another facilitator for this project is the setting. The outpatient clinic is a clean, well-organized office suite on the campus of the hospital. It's easily accessible. A majority of the 1,000 patients seen for stroke at the adjacent hospital are actually referred to the clinic for follow-up care. These patients are typically seen, on the whole, within 3 months of discharge, and the patients are cared for by 1 office RN and 4 advanced practice nurses who rotate outpatient stroke clinic days throughout the month. Then there are our stakeholders. In addition to the team of nurses and nurse practitioners, we have an excellent team of 4 neurologists, including the stroke director and the office administrator, who are promoters of innovation and practice as well. The patients, they're facilitators. They're typically elderly with multiple comorbidities and reside in rural areas of North Central Florida. The majority of the patients are covered by Medicare or Medicaid or private insurance, and they have relatively few self-pay patients in the payer mix. Greater than 50% of the patients are under the care of primary care provider. They often have low knowledge, but they have a strong affinity for seeking medical care. So we've identified some barriers and we've celebrated our facilitators, but now it's important to take a closer look at some of the barriers. And the selection of an appropriate screening tool is really the first step in overcoming the biggest barrier of routine screening. So the PHQ-9 has been widely used to identify depression in the post-stroke population and has a sensitivity, depending on the study you look at, anywhere between 51 to 100% and a specificity between 63 and 97%. Most studies, though, find an acceptable greater than 80% for both. eCliniWorks is the electronic health record platform of the clinic, and it actually has the PHQ-9 built into it, into the chart as a drop-down menu. So in addition to this being an appropriate tool for psychometric properties, this is now something that is very efficient to use in the office. An additional stroke of luck is that the office RNs have been trained to use the PHQ-9 when they've floated to the affiliated psychiatric outpatient clinic. So the focus of this project really is to implement screening. And again, as a note, as such, the treatment of post-stroke depression is outside the parameters of the project. However, we do want to include some resources, including the Alachua County 24-hour mental health hotline to both the providers and the office staff, and potentially make this easily available for patients, as well as the psychiatric referral pathway, again, to the affiliated psychiatric office through our physician services group partners. So this is just a little bit more about the PHQ-9. It does not require any formal training for its use. Thankfully, it's free of cost. And again, it's on the drop-down menu of the office electronic medical record platform. But we want to increase the screening and we want to follow the American Stroke Association guidelines. And so what we'd like to do is use the PHQ-9 in a 6-week pilot where the office RN is going to be asked verbal permission and then appropriately complete the 9-question assessment on the patients, meaning if they said yes, go ahead and complete the assessment. And obviously if they've said no, or they want to opt out of certain questions, then they have permission and full knowledge to do that. So once this is complete, the office RN is going to then verbally relay the results to the providers. And this will be part of the patient's chart and available for clinician review. So for instance, if the clinician does not get to chart until later in the afternoon and really gets a chance to go back and look at the answers that were provided. On our screen, we just have a brief description of the scores for the PHQ-9. It's fairly self-explanatory. These 9 questions are asked, and a score of 5 to 14 could indicate a need for assessment of mild to moderate depression, with scores from 15 to 27 more concerning and more urgent in their need for further assessment. So here we are talking about a plan for implementation. Now, this project has been driven in large part by the DNP student, but it is still part of the Iowa model and still using a collaborative effort and a team. And so the team has determined that implementing post-stroke depression screening is a priority. It has created a trigger for the formation of this team and a review of the literature, again, led by the DNP student. So the evidence from this literature review supports the need to increase screening for depression post-stroke, and to use the PHQ-9 as a suitable screening tool. As discussed, some barriers for implementation need to be addressed. One barrier that we haven't talked about yet is this barrier of awareness. The stroke team RN and 4 APRNs are going to participate in this short educational model, really that will consist of a pre and post survey and an 8-minute video detailing more the incidence, the prevalence, and the risks of post-stroke depression. This educational model is going to be available to them via email invite in the 2 to 4 weeks prior to piloting the implementation of the PHQ-9 there in the office as part of the practice. The plan for the pilot consists of utilizing the PHQ-9 to assess patients in the stroke outpatient clinic, again, for signs and symptoms related to post-stroke depression. We're just assessing them to see if their score meets needs for further assessment. So following the 6-week pilot, per the Iowa model, the team will reconvene to look at data regarding the 6-week pilot. Some of the information that we'll be looking at would include the number of patients that were screened compared to the number that were not screened previously, which I hope will be dramatic, the percentage of increase in screening, the number of patients potentially identified as needing further assessment of depression. It's also important really to consider the impression of the participating nurses and providers regarding, the screening's utility, its efficiency, and how important they thought it was, and whether or not they added anything to the value of the outpatient clinic visit. Okay, so this is exciting, right? We have looked at some evidence, we've created a plan. I think now is the time, though, that we have to sit back and think, wait a minute, how are we going to know if this project has been successful? If it's ethical, sustainable, reproducible? Well, let's go back through our steps. First, we had the careful evaluation and appraisal of quality literature, and it has provided what has appeared to be the most optimal screening instrument. It has suitable psychometric properties, it's free of cost, it doesn't require formal training, and it's part of the existing electronic medical record platform. Great. We've completed an assessment of potential barriers. We have addressed the barrier of lack of awareness among providers by providing an educational component. We have addressed the barrier of efficiency by having the office stroke team RN provide the PHQ-9 assessment on rooming the patient. Values. We've looked at the values of the patient's family, and of the care providers. And we're considering all of that by asking patients permission to participate, asking the providers about their impression of the pilot and and its importance. We're also providing an opportunity to openly discuss any concerns about a patient's mental health with their provider and their option to be referred on for further psychiatric care if it's appropriate. Collaboration. This has been a collaborative effort, and in large part due to the guiding model that was picked, which is the Iowa model, as the guiding framework. And finally, the proposal includes some rigorous efforts to make certain that the project has been evaluated by an IRB and is actually exempted from IRB oversight, that private patient information will remain anonymous and protected, and that data are evaluated with appropriate statistical analysis to yield useful and usable results. Okay, so this is exciting. Let's do this already. But wait, we have one more thing to think about. How do we know when we get there? What happens after this pilot? Well, the plan for the pilot consists of utilizing the PHQ-9 to assess patients in the stroke outpatient clinic for signs and symptoms related to post-stroke depression. Following the 6-week pilot, per the Iowa model, the team is going to reconvene to look at data regarding the 6-week pilot. And this is going to include the number of patients screened, the percentage of increase in screening, the number of patients potentially identified as needing further assessment of depression. We're also going to evaluate the impression of the participating nurses and providers. We want to know how they felt about the screen's utility, its efficiency, and how important they thought it was in clinical practice. So in looking back, we've taken all of these steps. All of these measures have been undertaken to provide the greatest opportunity for routine practice of stroke patients to be a sustainable adoption of evidence-based practice change. Ultimately, the outcomes of this project and the lessons learned from it, from implementing it, will be available for dissemination in the form of journal articles, poster presentations, and professional presentations, and hopefully be easily replicated. Utilizing the Iowa model as a guiding framework, a question has been asked, and an option for an evidence-based answer is now able to be evaluated. I sincerely hope that you agree with me that this project development has been thorough, well-designed, and is now ready for takeoff.